It's my honor to welcome Dr. Pamela Riley with the California Department of Healthcare Services. In addition to being the Chief Health Equity Officer and Assistant Deputy Director of Quality and Population Health Management at DHCS, Dr. Riley's a pediatrician and a fierce and beloved advocate for children, youth, families, and health equity. She has championed and supported the inclusion of the voices of Medi-Cal members and family advocates in her work with the department, for which we are truly grateful. It's with real pleasure that I welcome Dr. Riley this afternoon. Thank you.
Hi, everyone. Thank you for that. You make me sound really good, but it's so glad to be here with all of you, and those of you online, thank you for being here. My name is Pam Riley. I have been at DHCS for just about 4 years now, and I serve as a lot of things, as you heard, Chief Health Equity Officer. I help oversee our quality and population health management work, and I also serve as our child health champion, really advocating for children and youth in our Medi-Cal programs. And I'm sorry that I wasn't able to join earlier in the agenda. Looks like you all had a packed agenda with lots of fun stuff, including a lot about Medi-Cal. But I will just share that I was so eager to participate in this meeting that I showed up here a month ago on February 23rd, thinking that I said yes. Nancy asked and I said yes, and I didn't read closely enough. But all that to say that it's really important for me to be here, especially as DHCS moves more towards actually hearing from our Medi-Cal members and caregivers. And my dream would be for us to have systems in place to include that up front and not as an afterthought. So I am just going to share a little bit with you. I'll go lightning fast, but and I won't probably go through all the detail in the slides, and hopefully you will have those. But just a little bit more about how DHS is starting to think about that and incorporate that. And it's really central to all of the Medi-Cal reforms. None of that is going to work unless we start listening to, engaging, hearing from members and caregivers to understand what works, what doesn't, but also to make sure that people feel seen, heard, and that they feel comfortable participating in their care, because otherwise none of this we're not going to get to the outcomes that we want to see. Okay, so just a little bit about I'll give an overview of what we're doing in this space. It sounds like you all have heard a lot of this already today, but just a reminder. So there's a lot happening in Medi-Cal, newsflash. But there's a lot, really it's with the goal over the last several years of how do we make Medi-Cal work better for people, right? I list this mostly not to read it, but there's, as you all know, there's a lot happening in terms of reforms in Medi-Cal to make it more member-centered, patient-centered, both with provisions in our managed care contracts, with all the initiatives, myriad initiatives through CalAIM, through a heightened focus on quality and equity, through trying to reform our behavioral health system. And then you see this little part at the bottom, recent federal actions, boo. But we'll get to that part, but it sounds like you've already gotten to that. But all that to say, there's a lot of emphasis with a whole host of initiatives working collectively to really improve the experience of care, to move towards more whole person care, to really focusing on making Medi-Cal work better for people. And I know that children's preventive care, of course, is not the whole story, but guess what? This is way better than what DHCS was doing a few years ago in terms of not talking about kids at all, right? So so I want to just state, DHCS has prioritized over the past few years areas that perhaps didn't receive as much attention before because maybe they weren't as expensive, but we looked at, based on the data, where are we doing poorly, and we're doing poorly for the core populations that we serve. Kids, maternal birthing populations, and behavioral health. So as part of the comprehensive quality strategy in 2022, DHCS named these 3 populations, core populations of focus, clinical populations that we wanted to make a deliberate focus on in our quality improvement and equity efforts to really see a meaningful difference in the outcomes for those populations. And we set a set of bold goals trying to reduce disparities and improve performance in particular areas by 2025, which, as you might know, was last year. But so we're still working on it. But basically, we identified these 3 focus areas, aligned a lot of resources and efforts around improvements in those areas, really to focus on improving quality and experience. The specific goal that we set for kids was around reducing disparities in immunizations. But again, not the whole story. But as I said, starting with elevating the focus on kids has made a big difference in trying to move a lot of these efforts forward. And we are also holding our managed care plans accountable for measures like improving quality in these areas in ways where they were not held accountable for in the same way. So that is also a big impetus towards focusing on how can we improve in these areas. And I do want to just give a nod to another, in 2022, DHCS released the Medi-Cal strategy to improve health and opportunity for children and families. I did not have a role in naming that, but it basically is intended to be sort of a summary of what we were doing and also forward-looking. How do we take the suite of services that we provide to kids and provide it better? So really focusing on how do we improve coverage and care and shift to a more family-focused perspective on delivering care. We set a number of priorities in that, and I just want to call your attention to so the leadership structure and engagement approach. I guess the leadership structure was me, but I think having someone sort of responsible for engaging more outside of DHCS, both within and outside of DHCS, working with our partners, working with community partners and members and caregivers to really hear what some of the issues and challenges are, and really trying to implement policies and programs that will enable a more family-centered approach to care. So all of these things have been laying some groundwork for promising improvements in DHCS in terms of improving care for kids in general. My apologies for the small print, but hopefully we will share the slides after. I do just want to take a moment to name our commitment to health equity, particularly in this challenging environment. One of my favorite lines that I like to say is equity, we're still doing it. But that sort of underlies a lot of the ways in which that we need to engage members, caregivers, families in a way that is inclusive, empowering, power sharing, really listening to those voices. I think that is a perspective that we need to bring into a lot of our work. And I think this, we laid out our health equity framework, which really focused on the building blocks of understanding the data and where the disparities are, where the needs are, focusing on improving the workforce to be more reflective of who we're serving, and focusing on quality improvement to reduce disparities in particular areas. One of the things that emerged from that is over the past few years, in our next iteration of the comprehensive quality strategy that we released this year, or was it last year? It all runs together. But member and community engagement actually has risen up from some of the work that we've done with the health equity roadmap, which I'll share, as well as just with our programs. It's very clear, that has to be at the center, or none of this is going to work, right? Or it could kind of work, but maybe not as well as it could work, right? So it's really an emerging focus that we've articulated at DHCS, that we have started to build in some ways to incorporate it more systematically, but I think we have a long way to go to make sure that it's not an afterthought. So we've done a lot of stuff, all of these reforms in Medi-Cal and all of these transformation efforts, a lot of effort and time and energy and partnership. Again, none of it's going to really work unless we figure out how to more effectively engage members, caregivers, families, communities in understanding, in knowing what we don't know, because that's the only way that we can do this. As you all know, you've heard all about this all day. HR 1 doesn't make this easy and actually makes it a lot harder, right? All of the work that we're trying to do. I won't go into all of it, but you know, like, people are going to lose coverage. It is going to be harder to get care. It is, yes, many negative impacts and fewer resources to do the work. I think this makes it even more important, all the more important, that we figure out effective ways of including members, caregivers, community partners to more effectively understand what the needs are of the populations that we are serving and to identify more effective solutions to meeting those needs. There's no other way to do it. We have to engage people. And this is just, you all know this already, but we know this is important. I think the point here is that DHCS is now recognizing how critical this is and trying to build in approaches to community engagement in our policy and program development, and build in some, we basically are, there's an increasing recognition from our leadership level on down how critical this is. And there are a number of initiatives that we're starting to have a little bit more infrastructure than we had to do some of these things. I think there's much more to come, and we need a whole lot more. But I just wanted to share a little bit about like what it is that we are doing. So we have DHCS member advisory groups it's a requirement, although we were doing the Medi-Cal member advisory group before it was a federal requirement. But so there's some sort of DHCS requirements. There's managed care plan requirements, our primary partner in a lot of these improvement efforts, to have community advisory committees. And then we have made some deliberate attempts to engage members, caregivers, voices in development of specific priority initiatives. So I'll just share a little bit about those too. But like I said, if we can think about ways to incorporate this systematically across the board, that would be ideal. So you may be familiar with the DHCS Member Engagement Medi-Cal Member Advisory Committee and the Medi-Cal Voices and Vision Council. These are fairly new. The Member Advisory Committee is for members and caregivers to really provide input directly to DHCS leadership, and the Voices and Vision Council includes some of the Medi-Cal Member Advisory Committee members, along with other partners, including health plans, community-based organizations, to provide that level of direct input to DHCS leadership. And these are fairly new, and there are likely more ways to optimize the use of these to provide that input. But as someone who's been participating and also hears the response on the leadership side, they've actually made a huge difference already in terms of what the leadership hears. Like, you might know something in the abstract, but I think when our leadership hears it from our members and caregivers, like, it just hits different, right? And they're saying, actually, this policy is in place, but it's not working like that. Or things that we didn't think about as we were sitting in our, in our office, right? In terms of that might matter for implementation. Like, oh, well, that's not going to work because of we don't know what we don't know. And I think there's an increasing recognition, not just of the value of this type of engagement, but it's essential. Like, you have to do it, or it's not going to work for the people that you're trying to serve. The managed care advisory committees, all the managed care plans are required to have community advisory committees, which includes Medi-Cal members and other partners that they actively engage on a regular basis and present issues around how the plan is engaging with the community, quality improvement initiatives, community reinvestment, and community health assessments. So there's, we have, the plans use them quite differently, but many of them are doing pretty innovative things in terms of using those community advisory committees to engage their members and to develop some, out-of-the-box solutions to some challenges that they're seeing that might not show up if you're just looking at, oh, here's a quality improvement approach. It says I do this, that, the other. How are we getting people to show up for well-child visits or prenatal or postpartum care, like thinking about different ways of doing it, getting input from people, like trying to think about how do we do things differently and using members, caregivers, community members to give us that information, like tell us what would work, right? So I think it's, and a lot of the health plans have had a number of successes in that area. I did just want to talk about some of the priority initiatives that we have made a lot of deliberate effort to focus on, including member voice, member caregiver engagement as a core part of the development. This is a newer practice for DHCS, and we've done it in two major initiatives, our birthing care pathway and our health equity roadmap. But, it would be great, like I said, just to build this on in, right? So the birthing care pathway, for those who aren't familiar, again, improving maternal health, birthing outcomes for birthing people, a priority area. We all are aware of the poor outcomes and disparities in this space. We really set out to, with a lot of the opportunities that were coming online in terms of expansions of coverage, prenatal, postpartum, to develop a care delivery and policy roadmap from 12 months, from basically prenatal to 12 months postpartum. What should that look like? And what are the optimal policies and practices that should be in place to really optimally support birthing people to have better outcomes? And it really was intended to be a very holistic approach, addressing not just the clinical and physical health, but the behavioral health needs, social support needs, to really assist with achieving better outcomes for this population and reducing maternal morbidity and mortality. So part of this was that I'll skip to, there was a very cool part about member engagement. It was one of the key building blocks of this effort in a way that we hadn't done before. It was still, limited because we had limited budget, and these were foundation-funded efforts. But that part of this conducted interviews, I had a member voice work group, and had some members do some journaling. And what the team did was take all of these inputs and really look at, okay, well, what does this mean for what policies or programs would actually make a difference in addressing some of these challenges? And the end product of that was the birthing care pathway report and a number of policies that DHCS is enacting. But there were meaningful changes made based on that input and engagement that would not have otherwise ended up in the final report. So I just want to highlight, because I think these are things that we know, that you all know, but I think it's heard in a different way when when the department is actually doing the work to engage. The key findings from the member engagement for the birthing care pathway, there's a lot of alignment with what we know to be true. Feeling respected and heard is number one, right? Feeling that somebody is going to listen to you and your concerns and see you as a human. And again, it doesn't necessarily, like we could be talking about birthing care, we could talk about, maternal health, we could be talking about health equity and disparities. Treat people as people, right? And I think that's a huge, just come in with respect. The next one is really the experience of like discrimination in healthcare encounters. That's a very, as you know, that is a very real thing, but that is across the board. That could be for any number of reasons. But people don't want to go in. Like if somebody's not going to be respectful to me, I don't want to be there, right? So how are we, and trust building, as you all know, like that's an area where there are opportunities to build that trust that frequently get missed, right? Or that frequently get, negatively reinforced, right? So these are things that, we don't typically, like when we're doing a quality improvement plan, this isn't typically there, but like it needs to be there because none of this other stuff is going to be effective at improving outcomes, reducing disparities if people don't want to show up because they don't feel respected and heard, right? Systems are complicated to navigate. I don't need to tell the people in this room that. And providers that accept Medi-Cal for whatever the need is, particularly for mental health. And finally, understanding the slew of benefits and services that are available, which is complicated. Yes, again, you all know how challenging that can be. So, but these are just shared challenges that I think we have to have that member and caregiver engagement to even understand what's working, what's not working, in order to make improvements. The other initiative I just wanted to talk about is the Health Equity Roadmap. I'm going to pass, this is a little bit confusing. This is one of the outcomes of one of our community engagement listening sessions with the Bakersfield American Indian Health Project, but I'm actually going to skip to the next slide. So the Health Equity Roadmap, which is another one of my DHCS babies, shall we say. It was part of the comprehensive quality strategy and that equity framework built in with the recognition that, again, we are only going to get so far. We know what to do, and we've got a lot at play in terms of improving quality, coverage, and access, and it's not, not perfect, but there's a lot we're doing, right? None of that is going to matter unless we listen to people to really understand why, where are the issues, where are the barriers to getting care, where are the issues and challenges, particularly, and it was particularly with a lens towards racial and ethnic disparities, although there's absolutely other disparities that we intend to look at around sexual orientation, gender identity, and disability, behavioral health, but seeing as, we know that the root of a lot of what we see in terms of poor outcomes is systemic racism. We really decided to focus initially on the racial and ethnic disparities and the poor outcomes that we're seeing. And how do we include member and community engagement at the center of that in order to understand, why people might not be engaging in care. I always think back, I know we all saw this very starkly with COVID, but at the time I was working in Washington, D.C., which I thought, pre-COVID, I thought, I was the medical director at Medicaid there. And when I started working there, I was like, this is great. This is an urban area. There's no, shortage of healthcare providers. At that time, 96% of people had coverage. And I get there, I'm like, oh my God, the outcomes are abysmal. Like, what is going on here? And I think, COVID just made it even more stark that, somebody could have a clinic right across the street and still not go in for a whole host of reasons because, they don't feel comfortable or they're, don't want to be discriminated against or, somebody they know said that's not a good place to go. Like, there are so many of these things that are real, that have a real impact on whether, when, how people seek care, on their experience of care, that we need to start naming and making more tangible and including space for in these improvement conversations. So the goal of the roadmap is really to come up with a set of policies for okay, here's some things that DHCS can do better. And a lot of that will be in partnership with others, right? But here are a few, policy areas where we can, if we made these changes, these would make a big difference in advancing equity for the populations that we're serving. So it's been a bit of a long haul because I think this was intended to be different, not the typical, here's a DHCS initiative, run with it, no matter what anybody else says, right? It's supposed to be a co-design process. We haven't done this, right? But really starting off to okay, well, first we need to listen, right? So we conducted a series of Medi-Cal member feedback sessions across the state, half virtual, half in person. Just, just like, what is it that we need to know? We got to start somewhere, right? So we started with just, listening. Where are the biggest issues and challenges with coverage and care in Medi-Cal? And this is a little blurry, but this is just a list of the places that we went. And again, while we tried to broaden the reach with doing virtual, I think we quickly realized in person was absolutely it. Like, it was just a whole other exponential level of not just engaging, of being present, of hearing people, of forming partnerships with these community-based organizations. It was extremely valuable to our staff to participate in. You all know this and do this in your work, but this is not necessarily something that is routinely included in DHCS engagements, but really, how do we make sure that people feel seen, heard, and validated as experts in their care, and make it easy and remove barriers for them to participate in these meetings and honor their participation and engagement and provide compensation. So again, just highlighting a little bit of what we heard, a lot of what we heard, very similar to what we did with the birth and care pathway, and very similar to what a lot of you already know. Respect and discrimination was like number one. Again, people don't want to engage in a place that they don't feel respected and feel comfortable. We heard a lot of, we need better, just general customer service from, when people are trying to get their coverage, maintain their coverage, or use the benefits that they have access to. It's not always easy, right? And it's just, we need better, hey, how was your day, right? We heard a lot about quality care, but I think one thing that we heard touched on was quality in the formal sense, but also perceptions of quality. That really matters in terms of people's experience of the care that they are getting. A lot of challenges with how are we, using coverage? Can we get how do we get what we have access to? How does it, how do we make it easier? Better access to some benefits, and I will just say, for the earlier conversation, one thing we heard everywhere was dental. Everywhere. And, the state budget being what it is, I don't know that we have here's, what we can do brand new shiny for dental, but there's a lot we could do better, right? I think there's a lot we could do better. And with all of this, there's a lot we can do better with what we already have. We're not going to get new resources at this juncture, but there are core functions of what we're doing that we can and need to do better with just the basic functions so that people experience more equitable care and in turn better outcomes. And the thing that I communicated to my team and to our leadership is, I think what we learned too is this was about the content that you just saw, but it was less about that and more about the engagement process that was really important. We learned, the equity process of engagement, it's the process is just as important as the outcome or the thing that you're going to focus on. Because yes, equity is just as much a process as it is an outcome. We had to work, we are not the trusted entity, come talk to DHCS, woohoo. But, we worked closely with community partners, which that was the key for us. And basically people who work with the people that we're trying to connect with and reach and serve. And it really solidified the role of member and community and caregiver engagement in this process. There's no way to do it without that. So more to come on the health equity roadmap. The goal is to put out a roadmap. I keep saying it's going to be this year. So it'll probably be early next year. But basically to sort of align with, here's what DHCS can do in this space. But all that to say, I think what underlies all of this is that member and community engagement at the core. It has to be there or none of this is going to work. We do, so my goal, like there are some opportunities coming up where, again, I won't go into great detail, and my friend Nancy over here is so good at waving the flag, like, hey, we can provide input over here, which is amazing. But what I would love, again, is we have some building blocks. We have people aware that, yes, this is an important and good thing to do. How do we build that in so that, again, it becomes central and not an afterthought, because it is member and community and family engagement. It's our biggest untapped resource for improving quality and equity. So I will stop there, I think. Yes. Thank you. Questions, or I'm getting booted? Oh. Okay. That is if there are questions. Lori.
But then Zoom can't hear you.
I know the Zoom can't hear me. Thank you so much, Pam. I really appreciate it. Obviously, this day is devoted to the needs of kids with special health care needs and their families. So, and I understand, and you, I think, made the good case why the initial focus from the Department for Kids is on prevention, and of course that ship, I would say, is sailed, but it's not even relevant for a lot of the kids we're talking about. So how do you envision building kids with special health care needs and their families into your approach to health equity?
So my hope is that we can build in like some core principles and practices for all the work that we're doing that doesn't just, so, you know, the equity work is across the board. And so we hopefully can, you know, it has to be sort of high level in general because we can't do everything. But like I said, if we can get to a place where all of the programs, you know, CCS, like all of the programs that we're doing build that in to the process, I feel like that's going to be where the real opportunity is. So there's no immediate plan, and we can talk offline, but yes. But, you know, and other than also, but thinking about too, like, how do we use, well, we do have like ECM, for example, and bring in that caregiver perspective. And, you know, Nancy's on that. But yes, but I feel like we need to start thinking about that, even if it's not part of the health equity roadmap. Like, there's still like work to be done across the board. How do we think about building that in more systematically, even if it's not part of one of these other initiatives?
Hi, thank you for your presentation. I'm just wondering if maybe one pathway to that would be including maybe CCS families into some of those new committees and listening sessions so that you can so that they can be directly impacted in that way. You're hearing the voice directly from the families and or providers that are within the CCS universe, and I think that could be a great pathway to begin incorporating this specialized unit of families.
That's a great suggestion, and I completely agree. I will say that it's still an uphill battle, even within DHCS, to kind of bring that into the process, but absolutely, yeah.
Hey, Dr. Riley, fellow pediatrician, total fan of yours. But I know I'm like a total fanboy. When sort of piggybacking on the health equity and children with disabilities in the state, and the fact that when we support children's hospitals, it actually improves the care for everybody, all children, and looking at the Medicaid cuts and the cuts to institutions. I know that in this room, there's a medical director of one of probably the #1 children's hospital in California, and I'm concerned financially for them. One of the key parts of CCS is actually that care for children with CCS get that reimbursement for that care is at a higher rate than Medi-Cal. It's like 39% above Medicaid rates, and has been critical to children's hospitals staying healthy. But with all the other cuts and everything, the hospitals are going to take a hit, and I'm really worried about them going bankrupt, and wondering if there is thought at your level about how can we support those critical hospitals in critical places that are serving the most vulnerable populations.
Of course, you ask a question that I don't have direct insight to, but I will tell you that our finance teams, like this is, it has come up before and it's coming up acutely now, having conversations about how do we support hospitals in being able to continue to serve the community. So I don't know that I have any direct insight to share, but other than that, like, it actually is on the radar of department leadership and an issue that they're very much thinking about and recognize the critical importance of that. All right. Well, thank you so much, everyone.
Thank you so much.